Right. Hello everyone, my name is Tony Manton. I am the Aboriginal ITC Access Coordinator for the PHN. First off, I would like to acknowledge that I'm hosting this webinar on the lands of the Awabakal people, and I pay my respects to Elders past, present and emerging. And also for all the Aboriginal people that are joining us tonight on tonight's webinar. Just want to remind you about Slido. So we have Slido where you can actually ask all your questions. So if you go to slido.com and enter hashtag PHN8 and then you can ask any questions via the Slido there. So I'm going to give you a rundown of our agenda tonight. We're going to start off with Dr. Kat Taylor, who is a public health physician for Hunter New England LHD, the PHU. We're then actually going to stream to Dr. Catherine Todd from the Central Coast LHD, who's also a public health physician. We're going to have an update from our executive, Catherine Turner. Kylie Taylor and Tammy Buckland from the local health district are actually going to do a presentation. We have Dr. Ellie Warren from Yeren AMS and Dr. Karen Nichols from Tobwabba AMS. Then we will hold a panel discussion. So let's stream over to Dr. Kat Taylor for her.
Thanks everyone. So you can see that this infographic is largely identical to the one I presented a fortnight ago. There have still been no locally acquired cases in Hunter New England since the 15th of April. And in fact, on Thursday, we reached a very exciting milestone of releasing our last active case in Hunter New England from isolation. So at present in the district, there are no active cases of COVID-19. You can see that testing rates remain high. We've had the opening and ongoing operation of drive-through clinic in Cessnock, which has been extended to the 13th of June, and also the continued operation of additional clinics in Gunnedah, Glen Innes and Inverell. And the location and details of all of the clinics can be found on the Health Pathways site. So the question remains, what is next for us in this district with COVID-19? Some modelling suggests that it might be 6 weeks before we see any rise in cases following the easing of restrictions, which now happened 2 weeks ago. But I'm sure you and I would know just from heading down to the shops or to the park that people are starting to mix again, and we are seeing things starting to go largely back to normal. There's also going to be a substantial easing of restrictions from today. And we are actually, in fact, starting to see the effects of that playing out with respiratory lurgies now beginning to circulate in the community. Just going back to the flu tracking data, which I presented previously, we did last week start to see a rise in the flu tracking numbers. So rates of influenza-like illness in the community were sitting at 0.26% last week, which was, although still a lot lower than historic 5-year averages, was slightly up on the previous week. And then again this week, it's sitting at 0.37%. So the numbers are definitely on the rise and also in that under 5-year age group. And so I think the key message here really is that people still need to be mindful of those enhanced hygiene measures and social distancing measures, because if COVID-19 does get back into the community, the conditions are right for it to spread again.
Thanks, Kat. Hello, my name's Catherine Turner. I'm, as Tony beautifully introduced me, I'm the Exec Manager for Commissioning here at the Primary Health Network. As a proud flu tracker, I think it's always good to see the flu tracking results. We'll throw now to our colleague, Dr. Catherine Todd, who's based on the Central Coast, and Catherine will give us an update on the picture down there. Thanks, Catherine.
Great, thanks, Catherine. I'll just echo some of Kat's comments on the coast as well, where our numbers have been really good and have been for some time. So we're still remaining at 117 confirmed cases, all of whom have been released from active follow-up. So we have no active cases on the coast. It's been 24 days since our last case, and that's actually the only case we've had in the last 51 days. So we're certainly looking at over 6 weeks with only the one case, and that case had actually been infected 4 weeks previously. So at the moment, there certainly doesn't appear to be any residual transmission on the coast. At the moment, we're taking advantage of this lull to just focus on preparedness, anticipating that we may start to see an increase in cases now that we've had some relaxation of restrictions. Although, as Kat said, hopefully we've got a few weeks grace period before we do start to see a rise in cases if that occurs. So that's beefing up our ability to do intensive case and contact follow-up and making sure we're resourced to address any cases that occur in high-risk settings. A key thing I just wanted to share was that in light in schools going back and making sure we're having high rates of testing in kids as well as adults. Our COVID clinics that are run by both Gosford and Wyong hospitals have been upskilling so that they're able to do swabs in children. And so as of next Tuesday, they'll be able to do swabs in kids 5 and older. So if you have any kids in that age range that you would like to get swabbed and don't have the facilities to arrange something locally, please do send any kids 5 and over to the COVID clinics. We're still sending kids under 5 to ED to be swabbed, or there is the clinic at Erina that will do kids over the age of 12 months. So that's, I guess, it for the coast. We're just focusing on being ready for what may happen in the next few weeks, but appreciating that the success that we've had so far in getting our numbers down so low, which is an excellent effort on behalf of the community. Thanks.
Thanks, Catherine. It sounds like good news everywhere. So we'll all sit with our fingers and toes crossed and make sure we keep washing our hands, I think. So thanks for sharing that. I've a couple of reminder messages. One is, I know Tony's given you the Slido link and talked about the hashtag PHN8. We are ready and waiting to receive questions, which the panel will be able to address later on in our presentation this evening. So please let us know anything that you want to know a bit more about. Also, all of the information that we've been working on in relation to COVID is on the health pathways. So they're either on the Central Coast Health Pathways or on the HNE Community Health Pathways. Those links are also available going in through the PHN website, and I think we're going to put the links up on the comments section in Slido, and so if you're not able to access health pathways, you'll soon find out how you can, and I would commend you all to have a look there if there's information clinical or referral wise that you're looking for. So my task is a bit of an update from the Primary Health Network. So as you know, we've got a number of community respiratory clinics that the Commonwealth have funded around the region. Currently there's a clinic at Raymond Terrace, the one that Catherine's already mentioned at Erina, Tamworth. There's a clinic now operating at Moree at Pius, and a mobile service that's operating on a rotational basis between Gunnedah, Narrabri and Boggabri, and you can check the Oka Health website to find out where that'll be any day. Those are clinics that you don't need a referral for, and they're ready and willing to assist you with your testing needs. We are working very hard to get a clinic operating out at Taree. There's some building works that just need to be undertaken, which are well underway. At this stage, it's looking to be operational sometimes in the next couple of weeks. We don't want to be pinned to a specific date because it's relying on tradespeople a little bit, but sometime very soon that one will also be available for swabbing and testing. But we all know that the local health district clinics are all very much operational as well. So they're probably the key things from the PHN, except to say that we're just pleased to be able to continue to provide these updates on a regular basis as long as people feel like it's something that they need. So without too much more ado, I'm going to hand over to Kylie Yep, so Kylie Taylor, who's from Hunter New England Health, and her colleague Tammy Buckland, and they're going to give us a bit of a case study and talk about what happens when somebody is tested positive, I believe. And I'll let you introduce yourselves, and thank you very much.
Okay. Thanks, Catherine. And we'd also like to acknowledge that we're meeting on the traditional lands of the Awabakal people, and we want to pay our respects to elders past, present and future. And we'd also like to acknowledge those elders right across the lands and waters and everywhere that everybody's joining in from tonight. So my name's Kylie Taylor. I'm a Gomeroi woman originally from Walhallow and now living in Tamworth. And this is Tammy Buckland.
Hi, I'm Tammy Buckland. I'm a Burrupi woman, originally from the Comboing area.
Okay. In the first webinar that we did, we presented quite extensively about what happens for a public health response. Just let us flip the slides. And tonight we're actually going to present a case study using a scenario, and we're also going to explore the challenges that Aboriginal individuals and families may experience during this pandemic. And we're going to work through the public health and Aboriginal health response to case and contact management, and we're also going to talk about the conclusions so far. So we've got a scenario that we'll work through, and this is actually based on some real cases that we've done, but we've just de-identified and changed some of the information so it's not too identifying. So Kylie, who's me, I'm a middle-aged woman. I live 70 kilometres from a regional town in New South Wales. I work in health and travel a lot for my work. I share a small 2-bedroom house with 7 other family members, and I provide care and support and transport for my brother and an elderly cousin. I have diabetes and I suffer from anxiety, and I'm under a lot of stress at work, but otherwise I'm well. I've travelled away from work recently and spent a lot of time with one of my co-workers, Christy, who's actually been recently diagnosed with COVID-19. As one of Christy's close contacts, I was contacted by the Public Health Unit and was told to self-isolate at home for 14 days since I last had contact with Christy. The Public Health Unit also advised me that I had to have my own bedroom and I should not share any space with my family, and I needed to wear a mask for the whole time. This was really hard for me. The Aboriginal Cultural Support Team contacted me to see how I was coping and what supports I might need to safely isolate at home. The stress and worry of potentially getting COVID and then passing it on to my family actually really increased my anxiety levels. The Cultural Support Team contacted me every day to see how I was going, and together with them we organised accommodation for me so I could safely isolate away from my family who are really worried about getting COVID if I was to go on to get it. And I stayed there and they supported me until I was released from isolation, and the Cultural Support Team provided ongoing cultural care for me as well. Just in terms of case and contact tracing for COVID-19 in this situation, on the left, Christy is actually the person who's got it. And what we want to find out about Christy is where and how she got it. So we want to go back for 14 days and look at all the places Christy may have got it from. And in terms of me being her close contact, we already know that I'm a close contact because I was working very closely with Christy in the last 2 days since she became positive. And there's 3 other workmates there who've also been identified as close contacts. So the next step for us is, after being contacted by Public Health Unit, we're in quarantine for 14 days, and the Public Health Unit monitors us very closely, just checking for symptoms and checking to make sure we're going okay, and going through any troubles that we might have over those days, so we can maintain home isolation and home quarantine. If any of us start to get sick over those 14 days, then the advice is to go straight to emergency department or doctor or one of the clinics for testing. or that's different in each community, and it's best just to check on the Hunter New England website or your local or the New South Wales Health website or whatever state you're in. Check on those pages to see the most recent information about how you can be tested in your town. So we go and get tested, and if I test negative, then I still stay a contact and I still have to stay in quarantine for 14 days. And if my family chooses to stay together and I stay with the person who's sick in my house, in this situation I'm not sick yet, but if I was living with Christy and I stayed with her, my quarantine would now start after my last exposure to Christy, meaning Christy's home for 14 days and I'm at home for another 14 days. But in my situation, I'm a contact and I haven't been around Christy for 14 days. So if I don't go on to get unwell and develop symptoms or COVID, then after my 14 days, I'm okay. If I do get symptoms and end up positive, and then I become a case and now we have to contact trace for me. So that's the normal process for public health. So we identify the cases, we isolate the cases to stop further transmission, and then we trace all of the contacts, and then we just repeat that process. And then the other measures that are in place are social distancing and the other preventative health measures. What we decided is if we wanted to make a real difference from previous pandemics for Aboriginal people and communities, then we needed a different process, one that worked for us and our mobs. So far, we've implemented this process. Thankfully, we haven't had too many cases or contacts to try it out on. So we're still trying to really make sure that we've covered every base we can to make everything, as easy and smooth as possible if we start seeing more cases or contacts in our community. So the first step is with the Public Health Unit Operations team. They send a referral to the cultural support team, and that's just like an email, and we have some emails set up for that to happen to make sure that somebody gets it, so it doesn't matter who's off, that email will always be responded to. And then the cultural support leads, which is Tammy Buckland and one of her colleagues as well for the Aboriginal Health Unit. We then contact them and refer them for local support and follow-up, and I'll get Tammy to...
Okay, so our team is made up of 11 Aboriginal health workers and Aboriginal health practitioners. We've got one RN and a CNC just to cover, if there's any questions about anything that's out of the Aboriginal health workers or practitioners' scope of practice. So just in regards to the case, so the email had come through to me, the referral had come through to me on the Monday morning about Kylie being in close contact with a COVID-19 case. So it comes through with a referral with all the background information of what's happened since her contact. So it comes through to myself, I pick it up and I make a phone call to the case. So I phoned through to Kylie and I spoke to her about her circumstances, how her health was going and if any of her circumstances had changed and what her abilities to self-isolate were. So the important information to remember from the initial assessment was that Kylie is a part of a family of 7 people ranging from 1 year to 54 years. The space that she was in was not appropriate to be able to self-isolate, with it being 2 bedroom and 1 bathroom. Kylie's husband had a history of chronic disease, so I wanted to know what Kylie's understanding of what is happening was. What Kylie's understanding of self-isolating and what this might mean for her and her family. From here, we sought consent from Kylie to be able to refer her on to a local health practitioner in that area. And once we'd done that and we had identified with Kylie who the appropriate health practitioner in the area would be, I sent that referral through. I did a handover with the Aboriginal health practitioner and sent through all the background information as well so that she had a clear picture of what was going on. During that time, the day that I'd spoken to her on the Monday, she was then moved into temporary accommodation. So the next morning, the Aboriginal health practitioner phoned Kylie and went through everything with her. It's important to also identify that she had not been swabbed at this time because she didn't have any symptoms of COVID at all. So during the process of when the Aboriginal health practitioner would contact the case every day, the Aboriginal health practitioner would also feed back to me daily on what was going on, so that we were kept up to date with what was happening, and anything that was, if she developed symptoms or anything like that, then we could escalate that through to the public health ops team as well. So the feedback was continual, and during this time when the Aboriginal health practitioner was talking with Kylie, and they built up a rapport. Over the days, it became evident that Kylie had she disclosed that she'd previously been diagnosed with depression and had commenced on antidepressant medications. That meant that while she was just going into this temporary accommodation, she was also experiencing nausea, and loss of appetite, and she was really stressed at the time. So this also highlighted to us the importance of monitoring the impact that the self-isolation was also having on the case's mental health as well. So by day 6, Kylie continues to experience a headache. The Aboriginal health practitioner contacted myself, and I sought further guidance from the population health ops team, which had advised me that she would need to be swabbed. So the Aboriginal health practitioner in the area was able to accommodate this by sourcing out where she could be swabbed at and organising how the procedure would take place, how she would get there, how it would be done. So by 2 days later, we were told that she had actually been tested negative, but she would still need to remain in the self-isolation, in the temporary accommodation for the 14-day period. Through the ongoing contact the Aboriginal health practitioner had, we had a good rapport through with the case and with the practitioner. So as the days went on, the barriers were broken down and more information was coming out about how she was coping in the accommodation as well. It was very important with the team that we had a daily follow-up with everyone. So anyone that was dealing with the case, we had that follow-up. So the Aboriginal health workers and practitioners were always supported. And every day I would document all the findings that day, all the conversations, things like that. I would document that in MTIMS just so that we could do our daily tracings as well. Good, yeah.
Thank you, Tammy. And the next part of the cultural support, with the local referrals and the following up to and from the Aboriginal health workers and practitioners and back to Tammy and ourselves, that case is now, the only thing we have left to do with that is to ring back now that person's been discharged, and just to see how that whole cultural support process worked. But some of these things would not have been picked up without the cultural considerations that were given to this contact. So some of the things that we picked up through culturally supporting her, was the information about the house and how many people were living in there, the fact that there were 3 generations living together as well. Being out of town, if I was to develop symptoms, it was a long way for me to get in town. Somebody had to then drive me into town. My ability to maintain self-isolation. I had a husband with COPD as well, so if I was to get sick, I was putting him at very high risk of, he's one of my contacts now. The understanding of my responsibilities. When we first contacted the real person, she didn't really take all the information on board the night it got given to her, and she was about to go shopping to get food the next day, to tie them over for the next 14 days because she knew she had to stay home, but those real key messages on what it actually means and what her responsibilities are didn't quite sink in because it's a lot of information to take in. And there's also, going through that information, what it means for the family, and there's also the impact on the rest of the family and their stress levels as well. So all of these things got picked up along the way, and we were able to build that trust very quickly and very early with the person. And this information may have not been disclosed you know, to one of the CNCs who does the usual follow-up, or the Ministry of Health who are doing all the contact tracing and doing those daily, or, you know, 2 or 3 daily phone calls to the contacts.
Yeah, so this is just what we've recently talked about, what I just talked about with just our key points. I can't see that. It's just our steps that we went through, the day-to-day phone calls and the conversations that we had. It's the referral came through to me, obviously, and then I did the initial phone call. I connected her with a local Aboriginal health practitioner in the area to provide the holistic care and well-being care. She had the daily reports coming back for feedback on the cultural to myself, and the documentation into NSIMS was done. The cultural lead provides daily support, so that it's just so that, you know, well, obviously you're dealing with people that are very sick, and it's just so that the Aboriginal health practitioners and Aboriginal health workers are supported, and anything that needed to be escalated was obviously escalated straight away through to the public health operations team as well. Yep. So these are the forms. The first form is the form that we received the referral through from, and it just has all her details, how to contact her, the case and where she lives. The second form it's a series of questions that we use as a guide. So I wouldn't expect an Aboriginal health worker to just reel off these questions, because it's done in like you're yarning with a patient, like you're just having a chat. So you're getting the same information out, but you're not sitting there asking them, how's your mental health? You're just having a conversation. The third document is the feedback form, which is the Aboriginal health worker or practitioner would fill out all their case notes on and would email them back to me every day.
Okay. So, conclusion so far is we've had Aboriginal people leading the COVID-19 response for case and contact management whenever there's been an Aboriginal case or contact, and this will be the way it will be if there's a case or contact in an Aboriginal community as well, which is a high-risk setting. The working relationship with Aboriginal health and the integrated chronic care team as well. It's been important for other units to engage with Aboriginal staff, public health unit staff, AHU staff, PHN staff, and the Aboriginal community controlled health organisation staff. It's been a real team effort by everybody engaged from day one, and really supporting this whole process across the district. We're embedding the Aboriginal cultural support process as part of our public health response, and we can support the cultural management of Aboriginal cases and contacts. Aboriginal people must have the space to lead this work if we want to make a difference in communities and, into the statistics next time. We don't want to see those numbers we have in past pandemics. And the model of care can be adapted to suit the local needs, whatever your health district is, or, whether it's in an AMS or in a private GP practice, or, in a community. We can certainly modify and adapt that to suit the local needs. And we just want to say, thank you to everybody who's put a lot of work and effort into this, and hopefully we don't really have to get the chance to put it into too much practice, but we know that if we do, we have a big team of people who are ready to jump on this, to stop transmission very early and to stop community spread.
Thanks very much. I know there's some questions, but I'm going to hold them all till the end. But would remind people that we're ready, willing and able to take your questions via the Slido link. Thank you, Alison. #PHN8. It's really reassuring to hear so much work and that you're so ready, and you've been able to practice this once, and I hope you don't have to practice it again, but I know that you will be providing just the support that people need. So we're also pleased to be able to throw to Dr. Ellie Warren tonight. Ellie's there at our Erina office, and I think she's with us tonight with her Yerin AMS hat on. Ellie wears lots of hats across the coast, and we're really pleased to have her here, and she's going to have a bit of a chat about assessment and management of Aboriginal and Torres Strait Islander COVID patients within an AMS. So over to you. Thanks, Ellie.
Thanks, Sarah. Catherine, thanks for having me. Hey, and I'm calling in from Darkinjung country tonight. So I would like to acknowledge the traditional owners of the land on which I'm calling in from and pay my respects to elders past, present and emerging leaders, and also any Aboriginal people who are watching tonight. So I'll see if I can just share my screen here. And I'm going to take you through a slideshow where it was so great to hear from Kylie and Tammy about what they're doing as well. And this is another one of the success stories about really highlighting how the Aboriginal community controlled sector has been just incredible at being able to adapt to the emerging crisis. So yeah, let me take you through how we developed our Central Coast pandemic response plan for the Central Coast. So I'm not going to focus so much on individual patient cases or what we're doing in the practice, but more looking at the regional response and how we've prepared for clusters and outbreaks on the coast. So I'm Ellie. I work as the lead GP up at Yeren, Eleanor Duncan. And as everybody will remember, we really got very nervous around early March. So I don't know that many of us were paying so much attention in January when the first case was found in Melbourne in a returned traveller from Wuhan. But we all certainly got interested when Tom Hanks tested positive in Queensland, and then less than a week later there were already 5 cases on the Central Coast confirmed, and we couldn't find toilet paper anywhere. So I think things really heated up when the Ruby Princess let 2,500 people off into the community, and that was the sort of start of a bit of a, I would use the word debacle there. And we started thinking around then, you know, what do we do to protect our vulnerable community here? We knew from previous pandemics that Aboriginal people are more at risk of infection and more likely to get more severely unwell and require ICU admission during seasonal flu outbreaks and also H1N1 back in 2009. So we were on high alert and really wanted to make sure we had a good plan to help people isolate well, help them become educated about the social distancing rules and know what to do if there was a positive case. So by the 28th of March, there were 460 new cases in Australia that day, an average about 370 cases daily during that week at the end of March. And we'd already started thinking then about this pandemic response plan, and we really wanted to work out what could we do to help those people who were living in busy, overcrowded houses, perhaps with 10 family members in a 2-bedroom household with someone who's more vulnerable, perhaps an elder. How do we really stop that from becoming a serious outbreak and cluster if somebody brought COVID into the home? So we started drawing up a plan, and we really sort of pulled it out of thin air just by putting our heads together at Yeren with the CEO and called upon Steve Ella, who's the manager of Nunyara Aboriginal Health Unit at Gosford Hospital, and worked out how to really draw up this plan so that if we needed to put something into action, what can we do? And unbeknownst to us, government was coming up with a similar plan, and pretty much on the same day that we had finalised our response plan, they released the Australian Health Sector Emergency Response Plan for COVID-19, and we'd found that we'd pretty much mirrored their recommendations, but it gave us a chance to use that document to make sure that we're all on the same page and the right track. So some of the principles involved in creating this plan was really, it had to be community led. So that Aboriginal people really needed to be in charge of what was going to happen in the case of an outbreak, and what to do, how those resources would get tapped into, found, and just to make sure across the whole of the Central Coast that cultural safety was maintained. So we really wanted to be focused on data and using all the changing guidelines, staying on top of everything that was coming out of there, those recommendations from government and state level, daily changing recommendations, acknowledging that this community has certainly more social and economic disadvantage. We know that it's harder for Aboriginal and Torres Strait Islander people to access healthcare for many reasons. There's the lack of transport options and certainly higher burdens of chronic disease, and certainly overrepresented in homelessness, overcrowded houses, and those who are moving between houses as well. So from past pandemics too, it has been observed that perhaps the cause of easier transmission between Aboriginal people was that people move around a lot between communities, lots of visitors in between rural and remote and urban populations. And we were quite nervous that we really needed to get those messages out there early about social distancing and staying where you are, to avoid people here on the coast taking cases back to remote communities where they have family members. We found that we didn't need to be so nervous about that. This community has just responded so incredibly well, sensibly, really latched on to those public health messages. And in fact, a couple of weeks before, the rest of us got a handle on social distancing and the concept of flattening the curve, our Aboriginal community was already right on it. So it was fantastic to watch. A lot of our efforts went into really just making people feel comfortable, acknowledging that there's been some serious institutional racism in the hospital system and generations and generations of trauma in this population. And this has been a very anxiety-provoking time. Now's not the forum to discuss that, but we certainly see the impact of previous trauma on people's response to this situation. So the details of the plan itself, we wanted to make sure we could jump on a positive case quickly and prevent spread on the coast. So we work at Yeren, but we were very keen for this plan to encompass all Aboriginal people on the coast. So there are about 15,000 Aboriginal and Torres Strait Islander people living here. About 3,000 or 4,000 of them access Yeren as their main health service at the moment, and the rest see mainstream GPs in private practice. So it's really important for those of you who are watching from mainstream general practice to have a think about the patients that you see and how you can apply this plan to your clients and patients to keep them safe in the event of a second wave. So, I mean, the bulk of the success story here was how quickly we were able to collaborate with public health and Gosford Hospital, Central Coast LHD, and Andrew Montague, CEO, was on lots of meetings with us, really trying to share resources. At that stage in late March, it was very clear that we couldn't get enough masks or gowns or gloves or hand sanitizer or all of that thing. So that sort of thing. So we were keen to share resources and make sure everybody knew what their role was in the event of a positive case. And really still today, any positive case in an Aboriginal person will be treated like an outbreak because of the vulnerable nature of the population. So yeah, it's good to know now that we're prepared. So we created a pandemic response team which consisted of members from Nanyara Aboriginal Health Unit and our clinical team at Yeren, so 2 of our practice nurses and 3 Aboriginal health workers to provide that cultural support, similar to how Kylie and Tammy described. And we also had some oversight from the CEO and managers just to make sure everything worked pretty well. That messaging to community was really important. And we got on really, Facebook was our main source of access to the community. And daily messages went up out there. Our graphic designer was really heavily utilised and still is, generating our own culturally friendly little posts on Facebook. And this is the way that we reached, over 4,500 people during this time. So our response team is able to provide assistance with isolation. So whenever there's a house where it's not safe to isolate at home, we can actually now transfer that positive person to a different facility. So using the hospital's emergency accommodation, some earmarked hotels, to provide them with isolated care and support while they're recovering through their COVID illness. We can also provide packs of essential items and groceries, cleaning products to the family there while they're in quarantine as well, so the other family members who are staying at home, and really provide that daily monitoring and cultural support for all of the people involved in that case. And that would be with daily phone calls and home visits as well if needed. So we actually did a trial run of our retrieval and had a mock patient. So it was only myself and our CEO who knew that it was going to be a practice run. Everybody else in our pandemic response team really believed that it was a true positive case, and we successfully transferred a positive client from their overcrowded house to our emergency accommodation. And we actually, we do call our vehicles Thunderbird 1, 2 and 3 because there are 3 vehicles needed to perform the transfer safely with PPE and buddying for donning and doffing, and to make sure that other residents are safe and that the hospital or the hotel accommodation is ready to receive that person. So it was a big task to get all of this done, and we had written a plan and created this mock run within a week of really pressing go, getting it all started. So it was fantastic to see our team come together and the community, really sort of seeing how, I guess what I have to say is that I sit on a lot of meetings, as Catherine Turner has mentioned, and we can sometimes talk about bringing people together across organisations for months and even years and nothing changes. But in this situation, we've certainly seen how people can work together and really just make sure we do everything we can to keep this vulnerable community safe. So it makes me a bit emotional talking about it, because it really is, it's such an achievement. I'm so proud of everybody who's been involved. And so these posters are up now in the COVID clinics at Wyong and Gosford, and also in the Erina Respiratory Clinic, and also in all the private labs, so Douglas and Laverty testing labs too, and emergency at Gosford and Wyong. So if an Aboriginal person presents there for testing, they can call us if they're needing help with isolation and other things while awaiting their test results. So we can provide that service. And that's pretty much all I've got to talk about tonight. But thanks for listening.
Thanks, Ellie. What a fabulous piece of work, and I absolutely agree. Sometimes these things take forever, and it's just really reassuring when things can get done really quickly. So we're going to ask you to stay with us, because we've got some questions for later, which we'll be able to throw back to you. So the questions and the evaluations will be available on the Slido, and we're really interested in your feedback. So our last speaker has travelled here, is here from Tobwabba AMS, and to tell us about her experience in a similar vein, and that's Dr. Karen Nichols. So I'll throw to you, Karen, and I'll try and slip over here out of the way.
Thank you, and thank you for the opportunity to talk. Firstly, I would also like to acknowledge the traditional owners. I'm currently standing on Awabakal land. I'd like to pay my respects to the elders, past and present. I am a GP who works in Foster at Tobwabba AMS, and I have the privilege of working and living on Worimi country, and I would like to acknowledge the elders, the Worimi elders, and the Worimi people that I work with up that way as well. I work at Tobwabba Aboriginal Medical Service. We probably have about half the patient base at what that Yeren has, so we have probably about 2,000 patients on our books. The majority are Aboriginal and or Torres Strait Islander, and so our experience with the COVID-19 has been a little bit different. We have had to institute some changes on a smaller scale. So just bearing in mind that the process has changed from when the pandemic was first identified, and it continues to evolve as more information becomes available. But I'll just talk, and Dr. Warren presented a beautiful presentation which looked at some of the social determinants of health and the challenges and the importance of AMS in this space for Aboriginal and Torres Strait Islander people. I think I just might bring it back to perhaps a patient journey through the Tobwabba Clinic, just in the hope that maybe some of the other services might be able to get some ideas that might suit their communities, and also just acknowledging that the challenges for mainstream general practice will also be a little bit different as well when it comes to Aboriginal and Torres Strait Islander patients. So in the beginning, we actually had 2 doctors and the CEO go out to some of the homes to do some education with community members. Tobwabba's a little bit fortunate in that it is located on what was formerly known as the Old Mission. So the community live in the houses and streets around the medical service, and this is actually a fantastic opportunity to bridge the problem that can be there with physical access to medical care. So the CEO and 2 doctors went out just to answer any questions that any of the community members might have on the COVID and some of the changes that the government was implementing. We also utilise Facebook quite a bit to provide ongoing education, more so around the social distancing and the importance of hand hygiene, and that whilst, like everywhere else, we ran out of the hand sanitizer, soap and water is just as effective. There was also signage put around our clinic so that the people who didn't have scheduled appointments but dropped in to see a doctor could actually see quite nicely. It wasn't always worded, some of it was pictorial, so that they could see some of the changes that were being implemented, and to reinforce the hygiene messages and social distancing. We did have to cancel some of our services, transport being the main one, just until there was a little bit more clear guidance on what is recommended. NACCHO released a statement on that last week, so we're looking at what changes we can put in place to keep our workers safe as well as patients, and to be able to provide them with transport to appointments, bearing in mind that the local hospital is about a 40-minute drive away, and not all our patients have ease of access to get there. We did also institute the phone consultations, which the community have responded actually quite well to. It's been very useful, especially for follow-up on results, for testing for chronic disease as well as the repeat scripts and just the simple, easy things. It's meant that people can actually have their appointment, still go to work, not have to take time off work at a time when financially a lot of families are finding it a little bit difficult. There have been patients that have wanted the face-to-face appointment, so when that's been the case, we've educated reception staff on what they need to be asking patients and being explicit about what constitutes symptoms suggestive of respiratory tract infection and screening for COVID-19, as well as asking specifically about fever. And the patients expect now that they will be asked those questions when they phone, and when they present at the clinic we do tend to screen for temperatures. And the patients, again, we try and adhere to the social distancing rulings within the buildings. We've got it signposted how many people can be in any one room at any one time, depending on those rooms. And with winter coming, we're looking at a spot where we can sit patients that's not outside because it's just too cold, where we can keep them socially distanced. In terms of patients who have been identified as having symptoms, there are certain patients that we do see. We do have access to full PPE, and these would be younger children and perhaps people who have other significant comorbidities like asthma or COPD, who have shortness of breath, but not to a degree that we would suggest that they be calling an ambulance. And again, that just reflects our distance from the hospital and the difficulty that patients might have with accessing care in the hospital. So if we can do some of that management at the clinic, we will. The biggest challenge we see at the moment is actually the flu season, and that's going to be difficult as we come into flu. Whilst our immunisation rates are much better than what they were last year, we still haven't got enough of our population vaccinated for the upcoming influenza season. But the challenge will come with parents who have children with flu, with the return to school, and us recommending that those children have screening for COVID testing. So I think we'll actually see a change in our process. We meet fairly regularly to discuss where we're at, what recommendations have come out, either from the Ministry of Health, looking at the health pathways and seeing what recommendations have been made there, as well as NACHO. A couple of other things that will be challenging is the management of chronic disease, because I think whilst there's a potential for the second wave for the COVID infection, we're going to see an increased rate of complications from patients in their chronic disease. So getting that message out that we can still manage some of that chronic disease over the phone and see patients, if need be, who have no symptoms. So they're sort of, I think that's where some of our practice will be changing over the next couple of months. And that's pretty much all I had to share. And thank you for the opportunity. Thank you.
Thanks, Karen. Don't run away because we've got quite a few questions. I'm going to do my best to moderate the questions and answers. So I don't know is Dr. Catherine Todd available to respond to one of these, Todd? There she is. Hello. Thanks, Catherine. Sorry to put you on the spot there. There's a question here about broad-scale screening. So the question is, is the government wanting all community members, in particular Aboriginal people, to be tested now that the restrictions are being lifted in New South Wales? So I think it's a question about
that's a great question.
testing.
Yeah, so at the moment, we we're continuing to really only want to focus on testing those who are symptomatic. And that is because, you know, a test will only give you a piece of information about a point in time. So even if we tested a lot of asymptomatic people today, we could tell you that today these people weren't symptomatic, weren't infected, but it wouldn't tell you about their risk going forward. And there's other ways of doing population level screening that are more useful, such as looking at blood test results. So certainly the focus is going to be on making sure that people who do develop symptoms are able to access a test and a result as quickly as possible, in order to take action that way, rather than looking at testing people who are asymptomatic.
Okay, thank you. This might be a question for our GP colleagues, so I'm going to put Todd on the spot and see if you could grab Ellie for a moment. So Ellie, perhaps, and you touched on this a little bit, Karen, how have Aboriginal people responded to telehealth in your experience?
That's a really good question, Catherine. We had historically thought that telehealth was not a good option for Aboriginal people. There was thought that there would not be engagement, that there's a lot to be said for having someone in the room with you and reading body language and non-verbal cues. That was our thought, but in fact we've seen that they've really embraced telehealth, so much so that we've seen a big drop in our non-attendance rate. So we've been able to improve our rates of 715 health checks over the phone. We're thankful that that item number was available through telehealth, and we've also been able to increase the number of chronic disease care plans and team care arrangements, but really focus on that chronic disease management because people are more engaged. So originally we started doing welfare checks from our GPs to check in on our vulnerable patients and our elders, just to see how they're going, have a bit of a chat about the COVID situation, and they'd find that they needed a script or a referral, and we'd be able to call them back for results. And that has really improved engagement for a lot of our community with the health service. I've been talking with some other members of AHMRC GP advisory group across New South Wales, and other AMSs have seen a similar thing happen with telehealth. So they've really embraced it, and it's been incredible. It's just how to hold on to telehealth and advocate for it to continue after September. Has that been your experience too, Karen?
Yeah, no, and I quite like the telehealth as well. I think it tends to keep both the doctor and the patient a little bit more focused. I'm a little bit inclined to go on a tangent and just have a bit of a chat and a laugh. So it's been very good for that. And doing the health assessments over the phone was not as difficult as I thought it would be. It's a good way, I think, to engage the patient in what some of their health priorities are. Yeah, so I'm hoping we'll keep it.
Thanks, and thanks to you both. I know here at the Primary Health Network we've just led an advocacy paper to the Commonwealth on behalf of all of the New South Wales PHNs, suggesting just that there are elements of the telehealth strategy that really need to continue. There are some expansions that we have asked for, and also some more work that we're doing and we know needs to be done around training for either clinicians or the community to participate in a telehealth consult, because it is quite challenging. But I know that there's lots of resources that have already been made, and I know local superstar Kelvin Kong has also done a really good one on how to engage community people with telehealth. So
Can I just add
Yes.
Probably worthwhile just acknowledging the health practitioners and being able to follow up through telehealth is actually, I think, from what I've seen, has actually been very good, and it's enabled them to be able to follow up patients and get acknowledgement of the work that they do. Yeah.
So that's a question, actually. It's a nice segue for any of the panel. So how have Aboriginal health workers and Aboriginal health practitioners been used in the response to date?
I'll just talk about in the local health district. So we're actually partnering, as we said, with the Aboriginal Health Unit, and they have Aboriginal health workers, some clinical nurse consultants, and they also have some health practitioners as well. I myself am an Aboriginal health worker. I'm actually based in the communicable disease team, and during non-pandemic work, that's my usual role, is to help, look at the way communicable diseases impact on Aboriginal families and communities. So there's obviously, if the person is seeing an AMS, then there's a role there for the Aboriginal health workers or practitioners in that service. Some of the cases and contacts who we've followed up so far, all of them for Hunter New England Health haven't been attached to an AMS at all, and they weren't under an AMS. So we've heard tonight the fantastic job that the AMSs are doing, but they're not in every town. And, a lot of the time their books are full and they're not taking on new patients, and especially during a pandemic, they're not seeing their regular patients. So that's been a bit of a harder space, I guess, and we didn't want to overburden the AMSs as well, because while some GPs and other places shut up shop, the AMSs continued their services and took on actually probably, more of that supportive role, supporting families, doing food boxes and drops and other things like that. So they actually, took on, the telehealth consults plus all this extra community support. There's definitely a role for Aboriginal health workers and practitioners, and each of the area health services, they can have a way that they're engaging. Not our cultural support model. It doesn't replace any of the clinical care that an AMS or a private GP provides. It's just in addition to. It's another layer of support that they may not be able to provide, especially the private GPs. So each local health district will be different in the Aboriginal health workers and practitioners who they can call on. But we've built in a surge capacity for our teams. We can surge internally within population health. We've got about 25 Aboriginal staff, and then we surge a partnership with the Aboriginal Health Unit. So Tony Martin and Tammy and Hannah and the team, and they've got 14 staff to surge for. And then we've also got our ops team who can provide the clinical support. I saw one of the questions was, if we get lots more cases or contacts, how would we manage that? Yeah, we have quite a big outbreak response, and we've managed to date with the big number of cases we've had with not too many Aboriginal people, because we do go into that surge mode, and we just keep getting more clinical nurse consultants on board and other staff to do the contact tracing and the case management. And depending on the number of cases and contacts in an Aboriginal community or an Aboriginal person, there's also that capacity to surge, and using the Ministry of Health staff as well. But for Hunter New England Health District, we want to keep that as local as possible, and we want to try and handle it first, and then we'll surge using the Ministry of Health, because they just don't quite have that local knowledge on the ground of the challenges and implications, and the politics and the relationships that have already been built and are maintained by local Aboriginal health workers and practitioners. So we want to try and keep it local before we have to, then we'll surge, they'll surge for us, not the other way around.
Thanks, Kylie. Did anyone else want to make a comment on Aboriginal health practitioners? I think Ellie does, Todd, if you... Ellie.
Oh, thanks. I would just like to expand on that. I guess the Aboriginal health workers in our organisation have been so key to our response and having the community feel comfortable with what's going on. So we have a staff of 70 at Yeren. And we, when the pandemic hit, we split the team into two. So we had half of our team working from home. And because a lot of the specialist appointments in allied health had stopped doing face-to-face, so there wasn't such a need for Aboriginal health workers to be transporting and accompanying people to their usual appointments. So we had everybody on the phone, really calling most of our clients to check in and see how they were doing, to provide that extra support and education about social distancing and flattening the curve. And that's proved key. Now we're finding that there's a disproportionate level of anxiety in the community here about COVID, even though we've seen such a great reduction in the cases. There's still a real reluctance of people to venture outside. They're scared. So we need our Aboriginal health workers to be engaging with those clients and helping with the messaging there. And I guess for GPs working in mainstream general practice, if you guys have a question or concern about any of your clients and patients, supporting them, reach out to us at Yeren or at Nanyara Aboriginal Health Unit. And also, Catherine, you might be able to speak about their Aboriginal Health Access Team, whether they can help from PHN reach into general practice and just provide that extra cultural support.
Thanks, Ellie. I will take that challenge on. So one of the questions here is about mainstream general practice and assistance in pandemic preparedness for them while they're preparing in general for their. So we've been assisting the practices in general with some advice around how to make sure that the practice is prepared for a COVID outbreak, and that includes things like our capacity tracker program, which we're rolling out currently, which will be one way to alert the PHN to positive cases, particularly, or the need to quarantine particularly staff in the practices, and also to alert us to challenges that you're facing in regards to flu vaccine and PPE. But also we do know, and there are a few questions here from mainstream general practice about admiring the level of supports available through the AMSs and asking what the situation would be for them. So yes, our Aboriginal Health Access Team have developed a lot of resources for mainstream general practice to assist them when they're looking after the community patients that are in their care. And we've got that information on our website. There's also the information on health pathways. And if you reach out to either the primary care improvement officers or the Aboriginal Health Access Team, we're more than happy to either give you a call or come out and see what it is that we can do. Did you want to add anything, Karen, or no?
Following on from that, there was a question if GPs do get that same level of cultural support.
Yep.
So the Public Health Unit provides cultural support to every case or contact that identifies as Aboriginal or Torres Strait Islander. So it doesn't matter if they're a patient of a GP or an AMS, or if they're not connected to a GP, because we follow every case or contact up. We actually the Public Health Unit has those conversations first anyway to see if they've been to a GP in the last 12 months. And if they haven't, then we try to connect them with a GP, and if there's no AMS in their area. And also if they are connected to an AMS, we can make sure that the GP knows, but we'd rather leave that relationship with the client, like with the case or the contact, depending on where they were tested, and if they gave, if they said that they wanted the report to go back to their GP, then their GP could find out like that. Otherwise, we could, if we thought that patient needed that extra support. But because we don't provide that clinical care at Public Health Unit or within the Aboriginal Cultural Support Team, that's really a relationship with the patient and the GP. But if it came up through our the Public Health Unit daily follow-up or the cultural support follow-up, that we thought this person needed to see a GP straight away or some medical pathway, we could definitely facilitate that. But yeah, any person who identifies right across Hunter New England Health, we will know that information straight away. And yeah, depending on if they're an AMS client or a private GP, yeah, they will all receive the cultural support follow-up.
Thank you. And while we're on testing and GPs, there's a few questions. I know that there's a lot of work going on with the hospital COVID clinics and the private providers about making sure that all reports go back to the GPs. And the challenge, of course, is, as Kylie said, if the patient doesn't say who the GP is, then you won't get it. But we are reassured that the clinics are all very much working on that. There's some questions here about when people attend the COVID clinics at the hospital or the community respiratory clinics, are the people asked to identify? And the answer I've got from somebody helpfully on the panel is yes. All patients attending the GP-led respiratory clinics are asked to identify whether they are of Aboriginal and or Torres Strait Islander descent, and I think that's the case for all of the clinics, and I think that wasn't the case early on and there were some challenges, but I believe that that's really been addressed, so that's good news. There's a comment here, I think this is for all of the ladies, and it says, well done, the presentations have been great, so just to pass that on. There's a question about testing children. So we know that that's a concern and a challenge. So we heard from Catherine about the Central Coast LHD clinics as testing children, and my understanding is also at the Hunter New England testing centres, they will test children 5 and over, and is that right? This is what my advice has been, 5 and over, and if not, they're assessed in the emergency department just to make sure that there's not something else that they need to be considered for. And as somebody mentioned earlier, the community respiratory clinics are testing all children over the age of 12 months, and I believe that's going okay at the moment. There's a number of questions in the Slido about resources for practices and for community, that culturally appropriate resources that are available, and there's some really good links here. So we can make sure this is available after the presentation, but and I know there's been lots of them, and my advice would be to have a look at these links. There's some questions about, there's one that's being bumped up here around examples of the assessment forms that are being used, and it says here, oh, I don't know how to pronounce that, but it's the National Aboriginal Torres Strait Islander Health Workers Association, isn't it? Oh, NATSIWA, thank you. I thought I'd get that wrong, sorry. So they've got an excellent health assessment that's available through them as well, yes. I'm told here. So yeah, have a look at all of those. But as I said, reach out if you think that you need some more assistance or advice. Ellie, there's a question here that says, is it possible to share the pandemic response plan?
Yeah, I was wondering about that actually, Catherine. Certainly the poster could go out on your PHN updates. It's probably good timing to share the details and the phone number for our service and what we can provide. I'm happy to share the regional plan itself. It's about 60 pages if anyone's looking for bedtime reading. Yeah, we'll probably do that individually, sort of for special requests. I'm happy to get email requests after the talk tonight. If anyone's interested in reading the full document, I'm happy to share that.
Okay,
it's actually gone to Nacho and Nacho and AHMRC were very interested in sharing that across the state. So it's been adapted to other AMSs. So it's great public knowledge. That'd be great.
Okay. If Catherine Todd's still there, there's a question here that's related to public health response. There she is. Hello again. It says here, now it says AHS, so I'm not sure what that means. Area Health Service, where I worked, advised in February that if someone needed to be driven to a clinic or a hospital, the driver should drive with the windows down as PPE. So whilst that doesn't sound very helpful, what is the advice about travelling in a car with somebody who may or may not be being tested?
Ideally, if they had a mask, that would be the best option, because the car is an enclosed space. So we certainly did have some people early on in the pandemic who had been driven up from Sydney by their relatives, who the relatives had been wearing the correct mask, and so therefore even though they had the long drive together, they were considered sufficiently protected. I think in the absence of anything else, and when there's no other alternative, rolling down the windows is making the best of a bad situation. So certainly if you're a family member driving a relative to seek healthcare, that would be the best thing you could do, but I would certainly think it wouldn't be a good solution for a workplace or other service to do that. I think if you suspect or know that someone has COVID, then you should be wearing the appropriate PPE to transport them, which would include the correct mask.
Would that include if you suspected that they had COVID?
If you suspect that they have COVID, then you should be wearing a mask if you have a reasonable index of suspicion. Again, if you don't think they have COVID, then I think it would be reasonable just to drive them, and rolling the windows down is a better way of making sure you're not in the same enclosed airspace. But yeah, definitely if you think that they might have COVID, I think it would be a good idea to wear a mask.
Thank you. I'm not sure, Karen, if you can answer this one. It describes in the case study, maybe Kylie or Tammy could, you talked about the client having nausea. The question is, if loss of appetite is a potential COVID indicator, is it loss of appetite or loss of taste and or smell? I'm not sure if any clinicians can help us with that one.
I suspect so, because the client had already been in contact with someone who tested positive. There's a low threshold for testing to see whether or not that person has COVID-19. And part of, my understanding is part of where we're at the moment is surveillance as well. So we want to pick up cases if they're out there. So again, it's that low threshold for testing anyone with any respiratory symptoms or other unusual ones that may have been linked to COVID-19 in the setting of having a contact would put their threshold up a little bit more, yeah. But I suspect that's why.
Okay, there's another question. I'll throw it to you, see if you can help. So, do we know the incidence of asymptomatic carriers in the community? And I know the answer to that is no. With the incidence of positive cases, will serial testing of asymptomatic contacts help, and is that part of anyone's plan?
I don't know if serial testing, but it's not part of the plan. I think, again, it would, from my understanding, it depends on when they're tested in terms of the illness. So there's higher rates of false negatives on day one of testing of symptoms. So if they continue to have symptoms or if they get worse, then you may actually retest them again. That's my understanding, and that would have been what my practice is. Yeah.
And because you're quarantining their contacts, if they are asymptomatic, you're taking them out for 14 days anyway. So hopefully that reduces their chances to then pass on COVID if they do go on to get it.
It's the magic question, isn't it? I mean, who out there is asymptomatic? Who in this room is asymptomatic and carrying? So, we all have to be responsible, I suppose.
Yeah, that's why the social distancing, and minimising that time you're spending together and that closeness together, that's where that makes, a huge difference.
I'll ask you this one, Karen. It says, is it okay to give school medical certificates for well Aboriginal kids with families worried about chronic conditions, e.g. kidney failure, despite reassurance? So I suppose that's people being hesitant about children returning to school.
Yeah, and I think part of that comes back to the schools educating the parents about safe return and what they've got in place to actually reduce the risk of transmission. My understanding is that the children are more likely to pass on influenza, which I think is a higher concern, and we send our kids to school every year with that risk, than the SARS-CoV-2. That's my understanding. I would probably be exploring some other aspects about why. Is there something more than just the health risk at home? Is there some other issues at school that the parents are not wanting that child to have to address? Is this a child that's starting to disengage from school? So I think you have to be a little bit more broad in your thinking about the connection of a certificate and infection. It could actually be some other issues that need a whole separate
Probably locational and situational as well. So depending on where the cases are, where there are hot spots, and it's probably more a local decision. If it's an enclosed, like if it's a discrete community where they're in lockdown or reverse barriers, so they've nominated to close themselves off, and they're doing everything they can to protect their communities. That's probably a local decision that can be made. And I think the AECG, or the Aboriginal Education Consultative Group, there's probably some room for them there to advocate in those spaces. While everybody's preparing for a second wave, Aboriginal communities are still preparing for the first. So we have to remember that we're at a different level of response. And while we're not seeing many cases, as we've heard, the risk is still there. And as we open up travel and open society up a little bit more, that makes the threat more real to our communities. So it's probably more a local decision, and Aboriginal communities and families and AMSs have done a great job so far in trying to keep it out. But now as we open up, that the risk and the threat becomes more real by others bringing it back in as we open those services up and people start, becoming, doing more face-to-face stuff. And then, it makes it very hard to try and stop it from getting back in. So, there's probably definitely some work that can be done there to help prepare schools who have a high Aboriginal population or who are, in Aboriginal remote communities where those communities are still in lockdown under the Biosecurity Act. So, they'll have different rules.
Yeah, thanks. It's a complex issue, as is the reducing of restrictions in general. And, just as you were talking about with your practice, and I know everybody's talking about with other businesses about how do you safely reintroduce contact. And that's going to be something I think that communities and practices and businesses need a lot of help with. Ellie's got a hand up, Todd?
I was just going to comment as well. We've had some requests from teachers and other people in other professions that their workplace has been asking them to provide doctor's certificates simply because they're aged over 50. And there's been some discussion in our practice, at least, about that. What does that mean? An Aboriginal person over 50 is more vulnerable to serious illness from COVID. I think in reality, it's not just being Aboriginal, it's being Aboriginal and more likely to carry that chronic disease. So more likely to be a smoker, have hypertension, obesity, diabetes, all of those sorts of things. So if you're perfectly fit and well and over 50, there's no reason for you to be staying out of society. Is that what you guys believe as well, Karen?
Yeah, and I have been issuing certificates for people in the workplace, but reinforcing my certificate reinforces the need for social distancing wherever practical. And a lot of the people that have been asking for them are people who have their own offices anyway and can implement those sort of changes. I just think that piece of paper enables them to go to their supervisor or their senior and say, I do need more access to hand sanitizer, and I do need you to make, provide a bit more education to the staff in the workplace. I think that's what it's done, because every time I've called them, they've been at work anyway. So I think that's what it's enabled. And I think this is probably part of that challenge, is that health literacy and addressing that, whilst trying to fix overcrowding is really difficult, we can at least say, wash your hands, just wash them frequently. If you sneeze or cough, into a tissue and put it in the bin or into your elbow and wash your hands. And if you're unwell, don't go visiting. So just reinforcing all the basic stuff that we can do just to keep everyone around us as well as possible. I think that's, education is something that we really need to work quite hard on.
Thank you. I have one last question, which I'll throw to you, Karen, and we probably only have time for one more. And I know you and Ellie talked about telehealth. So the question is, what's the approach for performing physical observations on a chronic disease patient requiring a 715 assessment? Is it recommended that the Aboriginal health workers do a home visit, or how are you managing that?
So that's been a challenge. So in terms of the 715 and the so blood pressures and weights and BMIs, the final recommendation when I've done them over the phone has been to either have those measurements done when the patient next attends the clinic. If it's someone who is however, because we do have Aboriginal health practitioners, I can do a referral to them, and then they can organise with the patient whether or not it is a home visit or whether the patient comes into the clinic. So if the patient's due for a flu vax, then we can get them to come in and they can have all those things done then. So we try and tee it up so that the patient gets as much done as possible, and including some of that preventative health stuff and then get their numbers. But if they've had their blood pressure and their weight and a clinical examination done in the last month, then I think that's pretty well. You could use those numbers. I don't think that much changes. We do blood pressures on patients every visit, so we do it well and truly more than the recommended, what's recommended in the Red Book for the RACGP. So I don't know about Ellie, but that's what we've been doing.
All right. Well, we've come to the end of our evening, and I'm going to thank all the panellists for, again, such a really practical application for how to help the community in this particular situation. So I'll thank Ellie and Catherine, and here in the room, Tony, Tammy, Kylie and Karen. And finally, we are really interested in your evaluation. So we've got more of this series planned in coming weeks. We want to make sure that we're ready to deal with whatever wave comes at us, and that we've got the community and the particularly the primary care community across the region absolutely prepared as best we can. So if you would go to Slido and complete the evaluations, if there's something else you would like to know about or you think that we're missing in passing on from the PHN or the public health units or anyone else, then just please let us know. But with that, I'll say good night and thank everybody very much. Thank you.
It's been years, but